Okay. So welcome everybody for this 23rd webinar of the iBreast book. We're trying a different theme this time. It's Back to the Future, AI, AR, and VR in breast surgery. I think this is the future. So it's interesting to see still a good number of people that have registered for this, because this is not surgical, it's something completely different this time. We have 4 great speakers and we have lots of panelists also joining us, all experts in this. So we have Jill Dietz, who's with our previous past president, immediate past president of the American Society of Breast Surgeons, talking about AI, AR, and VR in breast surgery. Then we have Fabien Real from Paris, from Institute Curie, talking about 3D virtual reality to improve surgical planning. Then we have Pedro Govia from Lisbon in Portugal, from the Champirmo Foundation, talking about the operating room in the future. And then we have Andrew Gums, who's currently in Los Angeles, and Andrew is going to talk about AI and the promise of autonomous actions. It's very, very interesting concepts. We have Giuseppe Catanuto, you have seen before a few times on the webinars, and Giuseppe is in Catania in Sicily. I have the pleasure of having Gerald Lipp, who's one of the radiologists that works with us here in Aberdeen, has done lots of AI in breast imaging. Later, we will be joined by Nadine Haram from London, who's running also a big AI project there. We already have nearly 300 people online, so we're okay to start with the talks. The first talk will be the talk by Jill Dietz, and Jill has given an excellent talk in the Breastix 24 hours. So the iBreast book had a session in Breastix 24 hours, and Jill has given a great talk in that session. So we're going to play that talk again, as it is very relevant and it is exactly what we want for this. So are you all seeing the screen?
Opportunity. I want to thank Isan, Giuseppe, Ash, Fahadir, and the entire organizing team for inviting me to talk to you today about artificial intelligence in breast surgery. You've heard a lot already about artificial intelligence, and from our previous 2 speakers, Dr. Lipp and Dr. Raka. And there are many different definitions of artificial intelligence. I think it might be helpful to focus on breast surgery and how artificial intelligence relates to that by just having a few definitions. Certainly, machine learning is a large field analyzing how computer algorithms and statistics can be used to autonomously improve through trial and error with pattern recognition. Deep learning is a vaster application of machine learning, and it really centers around the formation of multi-layered artificial or neural networks. This is very similar to how our brains work. Natural language processing is concerned with how computers process, analyze, and understand human language through unstructured data. Robotics is this marriage of electrical engineering, mechanical engineering, and computer science for designing, construction, and application of robots. And computer vision is how computers extract, analyze, and comprehend useful information from usually multiple images, and then how these algorithms are used to accomplish automatic visual comprehension. And this is how your robots can see. Does AI exist in breast surgery now? Well, every time you do an operative dictation, you're using natural language processing with Dragon. Machine learning algorithms already exist. Your anesthesia machines have software that can detect malignant hyperthermia and then suggest treatment pathways if that happens. For sensory processing algorithms, our patients are all wearing wearable devices and can be used for prehab and patient-reported outcome. Computer vision is strong in the world of screening mammography, And even virtual reality is now being used for our trainees. Let's dive a little deeper into natural language processing in breast surgery. Dr. Hughes and his group were looking at searching through the literature for papers associated with breast and other cancer susceptibility genes. And what they did is they used machine-based natural language processing and a computational algorithm with large numbers of annotated examples to help that computer learn and predict what's important. And they were able to then really show in this paper how this machine learning based natural language processing helped them to narrow this down. We're seeing more and more examples of using big data that individualize treatment plans. So the idea is to look at the patient specific data and then add that to millions of data points that are already out there in order to really focus on individual treatment plans. AI can even reduce unnecessary treatments. In this particular study, this group used machine learning to identify which high-risk lesions were likely to be upgraded, and then they could use this data to help surgeons know which lesions could be observed safely and which required surgical excision. When we look just at PubMed in 1 year, and we put in breast cancer and systemic treatment, 284,074 manuscripts came up. It's nearly impossible for the clinician to make sense of what is clinically relevant. This paper looked at using artificial intelligence to help with these complex treatment decisions for breast cancer. This group looked at using artificial intelligence to individualize radiation therapy in breast cancer patients. So putting in specific patient data, disease data, treatment data, and using those complex multi-layered neural networks to help precision and create precise radiation treatment planning. The plastic surgeons have been looking at AI for some time, and they're using AI in preoperative decision-making. They're using it intraoperatively and postoperatively. This particular study looked at some of the ethical concerns associated with using artificial intelligence in surgery, such as informed consent, making sure we're keeping that patient-physician relationship. One interesting thing they looked at is ensuring that the data we put in is going to be useful for what we are trying to extract. An example of that is if we use facial recognition software to tell us what is beautiful, but we only use women who are in Western or very wealthy Eastern European nations, then we're going to misconstrue what is beautiful to other countries because we're not putting the more accurate data in to get the accurate result. So it is important that we pay attention to what data we put in and that it is very specific for a specific outcome. What about robotics? Robotics can be of a great benefit. They provide excellent imaging, better ergonomics for the surgeon, and they can even have a third arm with 7 degrees of articulation. Probably the biggest downside is that you just can't feel, you can't touch, although newer robots are actually looking at how to accomplish these haptics with vibrations and feelings of pressure. So even the loss of haptics is being improved upon. certainly an expense is a downside to robotics. But robotics, is it really just mechatronics or the fusion of mechanics and electronics? Experts think that when you add robotics plus computer vision plus deep learning, that is when we are going to get to automated surgeries. This study looked at exactly that. They had trainees working on the Vinci Robot, and they put in multiple data points with expert physicians and found out that the robot could actually help train the trainees and improve their surgical skills. Robot-assisted nipple-sparing mastectomy has been done already, and there's multiple experience with it. What we need to do is make sure that we're analyzing both not only just the short term, but also the long-term outcomes with these new technologies. But it is possible that in the future, robots will be able to anticipate and even prevent human error during robotic-assisted surgeries. When it comes to computer vision, there are already marketed 3D optical scanners that can objectively assess outcomes to help with preoperative planning and improve shared decision-making and patient expectations. I think one of the trickiest problems when we are using preoperative imaging for intraoperative localization is the fact that preoperative imaging is often done in a prone position, whereas the surgery itself is done in a supine position, which means that the lesion can move several centimeters. Several groups are working on fusing modalities to improve intraoperative localization. This particular group has developed the Acuity AR navigation platform. This is a breast prosthesis and a video that shows the prosthesis. The surgeon using the HoloLens is able to see the structures inside. Using 2D ultrasound, that's also projected for the surgeon to see, as well as the trajectory of the percutaneous device they're holding with sensors. So what this MetaView Acuity device uses to provide the imaging is the preoperative anatomic CT or MRI, which gives the 3D X-ray vision, the real-time ultrasound tracking with a holographic overlay, then the sensors allow the intraoperative tool to be tracked with a holographic display of the trajectory and depth. And then using active registration, this navigation system can fuse the pre-op CT and MRI imaging with the real-time ultrasound to show the surgeon exactly where the lesion is, and then also tool tracking to assist the surgeon with accurate tool placement. So what does that mean for the surgeon? Well, when the surgeon is wearing the device, which includes the HoloLens, they can look at their patient from anywhere and see the anatomy under the skin. They also can see this 3D map of all the structures of the patient and the tumor. And when that surgeon moves around the patient, everything remains in its correct anatomical location. That ultrasound overlay helps the surgeon with real-time imaging, assessing both the pre-op imaging and the instrument. And that surgical tool is transformed into a holographic image that shows the surgeon not only the trajectory relative to the tumor, but also the depth of the instrument. There are a lot of future applications to this type of technology. For one, this type of technology can be combined with current wireless localizing devices to more accurately interoperably find lesions. Right now, there's cryoablation being done percutaneously, and our only option is 2D imaging. This type of device can help the surgeon more accurately identify the center of the lesion, which is critical for cryoablation technique. It may even allow us to increase the size of patients we can treat with this kind of technology. One of the other really amazing things about this technology is that when a surgeon is wearing the headgear, another surgeon, which can be in a completely different area, can see exactly what the surgeon is seeing. And when the mentoring surgeon points to structures, the operating surgeon is able to see what the mentoring surgeon is referring to. This gives us all kinds of options for assisting surgeons who are in low and middle income countries with mentoring situations with new technology, or if they come across a situation for which they haven't been properly prepared. Another opportunity is in assisting surgeons with performing high value care procedures like intraoperative radiation. One of the problems is that we need to have a physicist and a radiation oncologist in the room. And a lot of these breast surgeries are being done at surgery centers, and it's very difficult to get that radiation oncologist there. Well, using this technology, the radiation oncologist has better insight as to what's going on in the wound and in the patient than if they were in a bunny suit looking over your shoulder. So there actually is an artificial intelligence surgery hype cycle. And as you can see, we're pretty far along it. We've been through the trough of disillusionment and we're on the slope of enlightenment, which means what's coming next is that innovation in productivity and real clinically useful AI is going to be coming out and being trialed and used by many surgeons. The drivers of AI utilization in breast surgery are going to be those early adopters. They're going to seek volunteer and industry-sponsored and philanthropic support to get these AI programs up and running. Also, we're going to need policymakers to understand the value of AI in breast surgery, including the potential use of things like 3D HoloLenses as a substitute for in-person observation or mentorship. And this technology is going to drive high-value care like cryoablation and IORT and more accurate lesion localization. Uptake may be slow at first while these technologies fight for reimbursement, but they will become more relevant when a pay-for-value drives costs down. So I do think it is time to embrace AI in breast surgery. Thank you very much. I'm honored to be part of this amazing global.
And that was a great talk. And thank you, Jill. And I still remember that talk from the Breastics 24 hours. It was great feedback. And I thought that would be a great starting point for today's webinar, as it covers many aspects. But now we'll talk about many of those aspects in more detail, as we have many of the people that have used the actual VR and AR and AI things. So many thanks for that great talk. Fabienne is going to speak about VR in breast surgery. So Fabienne is one of the surgeons in Institut Curie in Paris, and he's going to talk about mainly Avatar, which is an VR tool in breast surgery. He's going to touch about other things. So it's great to have him with us today. Fabienne, are you okay to share your?
Yes, I am okay. Thank you.
That's great.
Thank you so much, Yazan, for this invitation. It's amazing. There is almost 500 people listening to this talk. Thank you, Jill, for the talk. So I'm talking now about Avatar Medical. It's a platform to unlock the power of medical images for surgeons. I have some conflict of interest because I'm one of the co-founders of Avatar Medical. So what is being a surgeon? It takes more than 20 years to train a toddler to become a surgeon. And when you are a surgeon, you need expensive and large team, anesthetists, nurses, surgeons. You need expensive tools. You need expensive square meters, operating room, hospital room, etc. And what is the real cost effectiveness of all our surgery? When you are being a patient is very particular. So as a patient, I want what? I want to understand. I want to get information. I want no surprises. I want highly trained surgeon, no stress, accuracy, no complication, no second surgery, no sequel, no relapse. And eventually I want empathy. Surgical preparation, what does that mean? We have to know about the disease. We have to know about the location of the disease. We have to know about the extension of the disease. We have to know about relation to nerves, spine, vessel, duct, bowel, artery. We have to identify the best techniques, the best tools, how many teams we need to perform the surgery, and we have to set up recovery and rehabilitation to know what is the best for our patient. And what we don't want is surprise. So patient and surgeon both need a clear vision. It's what we try to define with the Avatar platform, is a clear vision for precision surgery. We have to talk about precision surgery. It's not only medical oncology that are allowed to talk about precision medicine. There is a need for precision surgery. When we look at surgeons, we really immediately discovered that a lot of surgeons are not exploiting medical images. In a short survey, out of 60 breast cancer surgeons in quite large breast cancer center in France, we discovered that 51% are sometimes or often unsure about the extent of a breast cancer lesion. 42% are sometimes unsure of the envisioned surgical strategy. So what we know is that almost 100% of surgeons are interested in using a virtual reality solution that allows 3D representation of medical images. Okay. And the other very important point is that each medical image is very different. It's very different from the patient point of view, from the surgeon point of view, from the hospital, from the image equipment we need. There is a lot of variable in medical imaging. They are very numerous, and we have nothing to get all in one. So if you look at the MRI, for instance, it's probably the worst. You will get hundreds of sequences, and you will never know which is the best to really look at your patient, at the disease of the patient. So that's a big trouble for our daily routine. So let's see. I was supposed to have some movie here. Yes. So that's I apologize. You went outside of. So let's see what we can get from Avatar Medical platform. Here it's a breast cancer. So we go deep into the breast. You can see the multiple lump here. You see the cancer. There is mainly two tumors. You see the artery going back and forth from the tumor. You really see the chest wall. And if we go higher, you go to the armpit and you see all the lymph node. That's the level of the minimal level of images that we should get before performing any surgery, because it gives you the opportunity to think about what is the disease of your patient, where is the location, what is the extension, is there some novel structure around, is there something very particular here? And you can manipulate the images like your toddlers are doing now with the VR headset. So we do see clearly the tumor, the vessel, the armpit. We can crop, we can select some region. Here we will, we definitely see everything about the lymph node and the tumor, very in detail, much more than what we can get just looking at the MRI.
Fabian, is there a video supposed to run online? Because we cannot see a video. Is there
nothing?
We cannot see a video. We can see the slide, but it's not playing a video online.
Oh, I apologize. It was playing a video. Just in front of me is playing a video.
If you have the video separate, might be able to play the video separate, because we can see only a slide that is.
I don't know why.
Sometimes if you take it out of full screen, it works better.
Don't work anymore. Apologize, I'm going to try something else. I apologize for in front of 500 people. Let's see. But do you see my screen?
No, we need to share the screen again, Fabian. So we stopped sharing screen now. And if you play the outside video without the presentation, and we'll go back to the presentation, that would be great.
Do you see my screen here?
Yeah, and it is a video playing now. That's beautiful.
Okay, so here you see what you were supposed to see before. I was talking in the dark. So here is the cancer, breast cancer. There's two nodes. You see the vessel all around. We are going up in the armpit. You see the lymph nodes.
Is it my screen that froze, or is it Fabien's screen? Is everybody online with me?
I think it's Fabienne's.
Yes, we are okay.
We're okay. Looks like he stopped moving.
So there's something that has happened with Fabien's presentation. Sorry for that. So we'll wait for a minute, and if Fabienne is not back, then we might need to go to Pedro's presentation and go back to Fabienne in a minute, because I think Fabienne is, I think we lost Fabienne, to be honest. Sometimes that's a problem with technology. Pedro, do you mind then doing your talk?
Of course.
Because, and we'll get Fabienne to finish his talk after. Sorry for that, everybody.
Okay, I can introduce Pedro, who's a friend of mine, if you don't mind.
That's great. Please,
Okay.
Giuseppe.
So once again, I'm pleased to welcome Pedro Gouveia, who's a breast surgeon in Lisbon at Champalimau Foundation. And we met a couple of times. We had a lot of discussion about technologies in the field of oncoplastic surgery, or in generally speaking, breast surgery. He's also the head of the immersive lab at the Champalimau Foundation. And it's my pleasure to have him here with us, and next week in Milan at our Oncoplastic Breast Conference. So Pedro, to you.
Hi, good afternoon, everybody. Thank you, Giuseppe. It is always a pleasure to see you. And I also want to say thank you to Yazan to organize this webinar, and also to say hello to Jill, to Andrews, and also to Fabian. So today I'm going to speak about the operating room of the future, given the example of breast cancer. So some of the slides were already presented last July, and I'm adding some extra slides to you. So the world population is estimated to reach 10 billion, and 75% by 2050 of the Europeans will be living in cities. So we need smart and better health. And nowadays, we already have smart homes, smart hotels, smart cities, an entire ecosystem. But now we really need to improve patient experience. The patient experience journey needs to be improved in a way to give patients better outcomes, but also a better quality of life. So taking the example of breast cancer today, So when we are analyzing images of a breast cancer patient, we are analyzing patients acquired in MRI in the prone position with the breast deformed by gravity and the MRI coil, or mammography or ultrasound. And then the surgeon needs to analyze the images, to read the reports, and then to apply a cognitive fusion to understand where the tumor is and where the tumor is located. And with increased efforts of screening, the majority of these lesions are non-palpable, which means that as breast conserving surgery is currently the gold standard for local treatment of breast cancer, it means that the majority of patients will need an invasive procedure for intraoperative localization of tumor. Now, the most used worldwide is wire-guided. Here at Champalimau, we use carbon tattooing, but all these procedures are invasive. So the question is there a new way? So I would like to remind you also a great paper that I advise you to read, published in January 2019 by the Nature on a special issue about artificial intelligence, where this American doctor and colleague wrote a very clear paper on high performance medicine, the convergence of human and artificial intelligence. And nowadays it's impacting mostly the clinicians, predominantly via rapid and accurate image interpretation. So giving the human eye a way to see better the disease of a specific patient. Now, I present you the study on how to build a digital breast model. So we have done some research, and we just apply it on a cohort of patients, registration of a surface scan with the patient in the upright position. And then we acquire these patients in the MRI. And then we have made a post-transformation with artificial intelligence from MRI prone to the upright simulation. That's what you see. So you can clearly see the deformation induced by gravity and the MRI coil when patients are registered in an MRI machine, and then the recovery using a biomechanical model in your right, with trying to correct all the deformations that are induced by the MRI. So we published a paper on how to use multimodal fusion algorithms between breast MRI and the 3D surface scan, and what you get, fulfilling what Mr. Eric Topol was writing about via rapid image interpretation, that everyone, a doctor or even the patient, could see this model and to immediately see where the tumor is, tumor location, and tumor size. Now, the ability to see the tumor inside the patient's breast is also good for patients, as you can have a prototype as a tool that you can plan your surgery or your skin incisions, and to explain the patient what will happen, where the skin will be located, instead of drawing with a pen on the patient's body, and then it's some kind of awkward for the patient to be able to check his own body and to see where the scar is. So we developed this prototype, so not a product, it's a proof of concept, where we performed this breast MRI to surface scan fusion, which is a tool that we are able to explain patients then where the tumor is and what are the possibilities for surgery planning regarding skin incisions, for simple lumpectomies, and later on, we might be able to draw also how it looks like with a mammoplasty. So you are seeing a true patient with a breast cancer located in the inferior quadrant. And then we are just simulating the cylinder that we will take regarding the surgery. And it allows the patient to see the tumor and the skin incision. So it's just a prototype that I want to show to you about how we are using these patient-specific 3D models in prototypes to improve surgical planning. Now, then after performing this fusion, we started an exploratory research transforming these patient-specific 3D breast models into point cloud models, which tumor included, and we uploaded on a test on a HoloLens, an headset from Microsoft, and we synchronized that model with the patient's body, which is what you are seeing in the right images. So you can see one tumor in the left breast and the other one on the right breast. And so we have been working on a new solution, which is a non-invisible digital and intraoperative localization technique that potentially could replace standard invasive methods and potentially reduce re-excision. It could be an enabler for surgeons to perform breast cancer conservative surgery guided by augmented reality instead of using invasive localization methods. So we just published a proof of concept this year in January. And from this time, we have acquired the patient in the supine position in the operating room bed. And then we fused with the breast MRI, removing all the information from the breast MRI except the tumor, here represented in red. Now, there was a former team in Stanford that in 2017 tried to do the same thing, but they didn't apply a fusion process from a breast MRI to a surface scan. Instead, they used the HoloLens for simple holographic projection of the tumor. So they published 2 cases. One was a failure, and the other one, they could see a 50% displacement of the tumor regarding the real location of the tumor. So what you are seeing here is the vision through the HoloLens on a real surgery where you can see the tumor in the inferior quadrant represented earlier on that model that I showed to you, that allows the surgeon to immediately see where the tumor is, the location, and tumor size. And another use case that we are being also working on, so we were working on how to see a tumor inside the patient's breast, but in breast cancer surgery regarding breast reconstruction with free flaps, we are also using another method that we can see a perforator inside the patient's belly during a DIEP free flap reconstruction. So what you can see here is an angio CT that we do for all our patients as a planning when we are considering a DIEP free flap. And you will see on the right images, there are small blue dots. So we have patented an algorithm for semi-automatic detection of the perforators that we need to spare during the free flap reconstruction. So you can see here, while the testing is being running, we have using dual mapping methods, the classic one, and with the semi-automatic detection method that we have been using it. Now, what we have done here is also pretty similar what we have showed to you regarding the breast cancer models. So what you see here is a true surface scan of the patient fused with an angio CT. Now you'll be able to see, small spaghettis inside the patient's belly, which are the perforators of the profound inferior epigastric artery. So you can see that there are 2 colors of the same artery, one blue and one red. Now, when the color of the artery change, it means it's the intersection with the fascia. So we need to know where the perforator is in order to be able to spare the perforator and to proceed with the DIEP free flap reconstruction. Now, this is only as a proof of concept, and we hope in January to reach TRL4, applying it on a real surgery. So we call it AVA 4.0. Now, we have been using Microsoft technology. For the ones that are not familiar with the HoloLens, I will show you a small video of what this headset is and could do. So again, I must be aware that this is Hollywood. So it's just a promotional video from Microsoft, but it's just to get familiarized with the headset. Now, these headsets could enhance surgeons' skills beyond human perception, so allowing a surgeon to see beyond patient skin. Now, for you to understand how the operating room of the future will be, you need also to understand what this camera could do. So I'm going to show you something that will be used with the HoloLens in the operating room of the future with augmented reality capabilities. These small cameras cost $400, which is very good because we can use several of those in the future operating room of the future. They can work synchronized and to perform 3D spatial room mapping. I must say to you also that despite this technology is great, it is not still considered a medical device in Europe. So we can only use this as in a research setting. Now, the reason why I'm showing to you is to explain you the voyages. So we started on study breast volume, then how to produce a 3D digital breast model, then the proof of concept with augmented reality last year, published this year. But this is research. So we are now currently on TRL4. This is not a product and we need to scale it. And so now we have to build the operating room of the future with augmented reality. And that's why I show to you these cameras, because the proof of concept was done with a model and with the HoloLens, the model inside the HoloLens, and then virtually I need to grab the model and manually synchronize the model with the patient's body. So that is good for a cool demo, but it does not work as a product. As a product, everything needs to be automatic. And because operating rooms with augmented reality today are non-existent, Breast 4.0 is reimagining the operating room of the future. So we have imagined to have these Azure Kinect cameras on the roof of the operating room, performing 3D spatial room mapping, identifying the different objects that are in the operating room, including the patient, and then capture the patient, target the patient, and only then we could see and we can insert radiological data inside the patient's body, allowing the surgeon to see a specific organ, a specific structure, or a tumor inside the patient's body, as we need in breast cancer surgery. So I have here a small video that I would like to show to you. Okay, so this is the operating room that I showed before, and you can clearly see the cameras installed on the roof of the operating room, able to perform 3D spatial room mapping, and then the system will apply a digital anchorage image on the patient's body, allowing the surgeon to identify the tumor inside the patient's breast. So the system will work all together, synchronized, the cameras and the HoloLens and a GPU outside the operating room. So where are we now? We are on the AI camp. So after developing a cool demo, we need to improve our methodology to have a scalable deployment of Breast 4.0. So there are some key steps for the operating room of the future to be done in the future, because today does not exist. So we need to teach a computer to see and recognize the patient laying down in the operating room bed. And then we need an advanced computer vision system combined with an augmented reality toolkit to target the scanned patient. And then we need to automatically and digital anchorage of radiological data in the patient's body with live rendering and image modulation. This needs to be automatic, because otherwise it will be usefulness, and surgeons will not want to use it. And in the next talk, Andrew Gumbs will explain to you what happens when you teach a computer to see, and then what is happening within robotic surgery. Finally, what does that mean for autonomous surgery? So this system is also a future of opportunity, as Dr. Jill has mentioned it before, for surgical education, either virtual or assisted. And this is an experience that we have done recently. So we have done this experiment in August after failing this consequently. So we worked with Microsoft engineers to give us a perfect image on someone that is far away. So you are seeing an image recorded by the HoloLens, and then I'm drawing the skin incision to inform the surgeon where should be the perfect skin incision. Now you can see that in this image, there are still a problem of synchronization. So there is a 1 millimeter displacement between the ideal skin incision and the one that I draw it. So at 6-7 months ago, our displacement was about 2 centimeters. Now it's 1 millimeter in August, and now it's almost correct. So we are using also another platform, and so we are already ready for remote telementoring with augmented reality. Now, this is a future of opportunities, not only for breast cancer, but also for liver surgery, rectal surgery, vascular surgery, and vascular access will be a hot topic on this one. So surgeons will be able to see beyond patient skin, enhancing their human capabilities beyond what they are able to do today. And this is also a way for a better world. So REST 4.0 or AVA 4.0 are complying with the European Green Deal as a digital and non-invasive method for breast cancer localization. It could help reducing hospital waste, optimize the patient journey through the radiological exams. And we are also using cloud services that are running with 100% green energy. Now, as Mr. Eric Topol was saying, so this is all about the convergence of artificial intelligence with with medicine by improving human performance when we are treating patients. For clinicians, mainly through rapid image interpretation. For patients, it means a non-invasive method, no pain, no anxiety, no bleeding, no hemorrhage. And for health systems, this could be also a way to increase efficiency and to use resources where they are most needed, as, for example, better chemotherapy. Thank you very much. This is it. Thank you.
That's great. Many thanks for that, Pedro. And we have Fabienne back online, which is great. So great talk, Pedro. It's really eye-opening when you go and visit Lisbon and you go and see what Pedro has in the Champollion Foundation. It's a great place to visit. So if you're in Lisbon, please try to find Pedro and see what he does there. He does great work there. And they used to say the sky is the limit. I think now the headset is the limit, isn't it, Pedro? Now we'll hear about we'll hear about the headset from Fabienne. We'll go back to that talk about the VR, which has a great talk about the avatar medical. So Fabienne, do you want to share your screen again, please?
I can. Do you hear me?
We can hear you fine, Fabienne.
Okay, we will try. I apologize, but Zoom shut down twice already, so I hope I can finish my talk.
Hopefully you'll be okay.
I don't restart the whole talk. I was just showing some. I will stop the movies. I don't know if Pedro showed that he is able to show some movies. I'm not. It sounds like it shut down everything. So here are some pictures from Avatar Medical that we get from MRI. So the point is that the key benefit for surgeon using Avatar Medical is to perform efficient analysis, memory retention, and to improve the workflow and the collaboration. So it gives us the opportunity to get higher productivity, less mistakes, informed surgical decision, and precision surgery. So we performed some studies, and recently we published in GCO a comparative study with 18 surgeons of obstetrics, breast cancer surgical department, 90 breast cancer MRIs, and we compare how all these surgeons that are quite trained, because the number of cases we take care here is very large. So we compare standard packs and versus Avatar Medical. And what was very impressive is that we get a lot of time. We run 4 times faster using Avatar Medical compared to any slice-based platform. So that's a huge improvement, because if you perform 1,000 surgery a year, it's 1,000 multiplied by 4. So that's a great opportunity to spare some money and time and to perform other things during this time. So the second point is that we perform 25% less mistake when we use the Avatar Medical platform compared to the standard slice-based platform on breast determination, surgical strategy, number of lesion identification, breast quadrant. And what was another interesting point is that when we use Avatar Medical with the junior surgeon, immediately they get almost the same result than the senior surgeon. So that's an improvement, and it allowed us to give the opportunity to a junior resident to get a very high performance in MRI lectures. So that's pretty great. We published a case report in British Medical Journal, and we were able to show that Avatar Medical was a support to perform precision partial mastectomy. Here it's a very large multifocal tumor. We didn't know if we were able to perform a conservative treatment. We didn't know if we were able to really catch everything. And so we used Avatar Medical to better determine where were these different nodes. And when we performed the surgery, we performed an oncoplastic surgery. We were able to get everything to get a free margin and to get a nice aesthetic result. So that was a huge improvement compared to what potentially we'll do using the MRI slide-based routine, where a lot of people would say, okay, let's go for a full mastectomy. We were able to improve our surgery for very multifocal. On the left part of your screen, you see there is very tiny nodes, 6 different nodes. We were very able to see that in detail before performing the surgery. So the same, to perform precision partial mastectomy, you need to know better from your MRI. And the other point on the right side, on blue, you see a lot of DCIS in the lower part of the breast, and the same, we get a lot from this information to improve our surgery. Here is about visualization of vascularization. Using this Avatar Medical system, we are very able to see where are the arteries, the vein, and to determine which road we should use to when we perform oncoplastic surgery, and we are eventually able to discuss research question here, because it's a lot of information that we don't use in clinical routine. Another point is to compare before and after neoadjuvant treatment. On the left side, you see the tumor, two nodes, two lump in the breast, and a lot of lymph nodes. That was before standard neoadjuvant chemotherapy. And you see after the neoadjuvant chemotherapy, just before the surgery, the huge reduction of the cancer volume in the breast and in the lymph node. So you can compare that, and you have a very accurate perception of what does that mean in terms of tumor volume reduction. So we identified key benefit for the patient from a study of 70 cases. We were able to really see that there is a better understanding of the surgical decision. And we were even able to convince some patients using these devices. So what surgeons said is that I'm more confident in my surgical decision in 77%. I can better remember the image over time. I can better collaborate with the radiologist, and I can better train the interns for all of these topics. Avatar Medical platform sounds to be very useful in the routine. So now we have a lot of other pathology and surgeon involved in the development process of avatar medical platform for the sarcoma, for instance, for kidney aneurysm, for congenital disease, for gynecologic cancer, for head and neck cancer, etc. So we are working a lot to set up everything to make the MRI, the CT scan, every type of images are able to give the most they can to the surgeon before performing surgery. So now the team for clear vision for precision surgery start to be a very large team with a very different profile of people, and it's quite very exciting. And thank you so much for your attention. And I apologize, Yazan, very deeply to these 500 people not being able to show a nice talk, not cut in twice. But that's life. Thank you so much.
Fabienne, it has been a great talk, and you know that I'm really interested in Avatar in that in this product. I think it is great. The next talk will be by Andrew Gums, but before we go to the talk about with Andrew, which will be also fascinating, and I think it's the next step forward after that, I'm going to share a little video from Avatar Medical as they're sponsoring this event. Do you mind stop sharing your? That's great. Thank you, Fabienne, for that. So can you all see my screen?
Yes.
That's great. So a little video from Avatar Medical.
Avatar Medical, unlocking the power of medical images for surgeons. Avatar Medical's software leverages virtual reality and standard medical images such as MRIs and CT scans to instantaneously create realistic 3D patient avatars. In one click, surgeons load any type of DICOM image to instantaneously create a realistic 3D patient avatar. No segmentation is applied, enabling the surgeon to see lossless representations of organs through powerful real-time rendering techniques. By applying advanced dynamic filters, surgeons can rapidly highlight specific anatomical structures and textures such as tumors, vessels, or bones. In one click, surgeons are immersed in the patient's avatar with virtual reality. High-definition stereoscopy offers an intuitive way for the brain to visualize the organ. Surgeons can freely interact with the patient avatar and as such improve their mental simulation of the surgery. Avatar Medical is a spin-off from the Institut Pasteur and Institut Curie. The company was created by an experienced team of French and American founders. The solution has been tested by more than 50 surgeons with excellent feedback.
And that's great. And that's great from Avatar Medical to be sponsoring this event. And with sponsors like Avatar Medical, this is how we can continue doing those webinars, running them for free. And it's great to see that there's nearly 500 people online, and there's many senior surgeons. Like I can see Andreas Karakatsanis, I can see Andrei Jugulin online, I can see Michalis Kontos, and I see Stefan Vochelescu, Mustafa Ait Isa. Those are all very senior surgeons from across the world. And I see surgeons that have really changed many things in breast surgery and surgical oncology online, like Prof. Christos Markopoulos, who runs the European Board of Breast Surgery. It's great to have him online. And we have Prof. Ricardo Odisio, who's the previous president of ESSO, and I think nearly every surgical society in Europe he has chaired in the past. So it's great to have so many senior people online. Now, you all hear about self-driving cars, and Tesla have changed many things from that point of view, but are we going to see machines that we're going to do our operations? So we have Andrew Gums going to speak about that. And Andrew is the editor-in-chief of Artificial Intelligence Surgery, the journal. And he's one of the surgical oncologists that works between France and the States, if I'm not mistaken. And Andrew is currently now in Los Angeles. Am I correct in saying that, Andrew?
Yeah, I'm on vacation in Los Angeles right now, actually.
Enjoy the vacation, but we had to take those couple of hours from you just to get you on our webinar. Sorry for that, Andrew. The next 15 minutes are all yours.
Okay, you can see my screen?
We can see your screen all fine.
Okay, so thank you very much for this invitation. I should say that I am a minimally invasive hepatic, pancreatic, and biliary surgeon, but I was recently asked to become the editor-in-chief of a new journal, as mentioned, called Artificial Intelligence Surgery. It's the first journal dedicated exclusively to artificial intelligence and surgery. So we'll talk about that a little bit later. As you can probably tell from my accent, I am indeed American. I moved from New York to Paris 3 years ago. I currently work at Poissy and Saint-Germain-en-Laye in France. The title of my talk is Artificial Intelligence and the Promise of Autonomous Actions. It's actually the title of a book that I am publishing with Professor Konrad Karst from Munich and also Professor Narat from Poland. That's going to be published by Springer. The chapters are being reviewed right now and should be published sometime in the new year. So as mentioned, we have a journal that I'm going to talk about. Some of the other aspects of the talk, we're going to talk about the difference between weak artificial intelligence and strong artificial intelligence. We're going to focus on the 6 levels of autonomy and how they're different. We're going to talk about robotics and how robotics differs from telemanipulation all the way to fully autonomous surgery. And then towards the end of the talk, I'm going to give some real life examples of autonomous actions in surgery that already exist today. So just some examples of, I don't know why this actually appeared here, but I guess we'll talk about it now. This just talks about some of the algorithms that we use for autonomous actions in surgery. Talks about, we don't have time to go into these algorithms, but essentially to get to autonomous actions, we need supervised learning, such as support vector machines and random forests. And a further aspect of machine learning is deep learning, which is a form of unsupervised learning. A form of that, or something that falls under deep learning, is computer vision, which was talked about in Professor Dietz's talk, such as convolutional neural networks, artificial neural networks, and Viterbi algorithms. And as far as autonomous actions, what we really need to focus on, but we don't have time to talk about it in this talk, is reinforcement learning, which are principally done with Markov decision processes and deep QRL. So this is the journal. It was launched last year. I was asked to become the editor-in-chief a year ago. It's going to be published quarterly. The first issue is actually scheduled for January of the new year. So the website is aisjournal.net. This is what the website looks like. This is an editorial that I've already published about what is artificial intelligence surgery. It discusses some of the issues that we're talking about today. As opposed to artificial intelligence in medicine, I believe artificial intelligence surgery involves movement. It's a dynamic art, different from simply medicine, which is why I'm most interested in autonomous actions. As we talked, to get to autonomous actions, we need computer vision, which is why you can see most of the talks have focused on the computer actually being able to see. Because if the computer can't see, then no autonomy can occur. Nonetheless, as we'll see later, there are some examples of autonomy already. So this is from the editorial that I published. It was referenced earlier, and I'm not going to go over it too much because it's going to be, I'm going to show you some further iterations of it as I've kind of progressed in my thinking about this problem. All right, so I believe right now we've actually passed the trough of disillusionment right here, because you'll see a little bit later, we do already have autonomous actions. Okay. So artificial intelligence surgery involves autonomous actions. Current robotic surgery is really just a form of laparoscopy. It's just telemanipulation. There's really no significant artificial intelligence, okay? Artificial intelligence surgery implies autonomous actions. So what is weak artificial intelligence? Any automatic action is an example of weak artificial intelligence. But strong artificial intelligence, what a lot of people have a hard time understanding the difference between the two, is when the computer does decisions that it was not initially programmed to do. So it's hard to say that we are fully there, but believe it or not, there's even an example of that, which we'll talk about a little bit later. So what are the 6 levels of autonomy? Level 0 designates no autonomy. So that's standard open laparoscopy, standard laparoscopy. We know what that is. Level 1 is defined as telemanipulation of the robot. So the Da Vinci robot is an example of only level 1 autonomy. Level 2 corresponds to limited autonomous actions. We have some examples of that. Level 3 is defined as conditional autonomy, where the surgeon, selects among several autonomous actions that the robot can perform. Level 4 autonomous actions include automated medical decision-making under a doctor's control. And level 5 indicates full autonomy where no human control is necessary. We're not quite there yet, but as we'll see a little bit further, we're pretty far along these 6 levels further along than I think most people realize. So what about the 4 classes of medical devices based on risk? This is also interesting to understand. Class 1 devices have minimal risk to the patient and remain in limited contact with the patient and include things like surgical instruments. So surgical instruments are only class 1. Class 2 devices include things like CT scanners, ultrasound probes, and contact lenses. Class 3 includes hemodialysis and implants. And class 4 includes implantable defibrillators and pacemakers, which are actually wonderful examples of automation in medicine, because as you can imagine, as you know, an AICD is implanted in the patient. The computer detects an arrhythmia and it does a therapeutic action autonomously. So that is a very high example, in my opinion, of autonomy in medicine. That said, one wonders if a 5th class should be designated for devices that make real-time clinical decisions using artificial intelligence during procedures. So that'll be clearer as we get further along. So a lot of the algorithms that I talked about earlier in my first slide, which was out of place, so I apologize for that, is discussed in this article that was recently published in Sensors. They asked us to discuss how we feel the future, how we are going to get to autonomous actions in surgery. So if you're interested, it's an open access article and you can find it on Sensors. The good news, I believe, is that all surgeons already use artificial intelligence. Also, breast surgeons certainly are already using artificial intelligence. So what do I mean by that? Valley Lab was a company formed, I believe, in Colorado in the 60s. They are most famous for the monopolar and bipolar technology, TissueFect or tissue sensing technology. They actually analyze 434,000 data points per second. And this is a little bit easier to understand what I'm talking about when we talk about their Ligature device. This is a vessel sealing device that uses an advanced vessel sealing algorithm. Now, the machine will take longer to cook larger vessels than smaller vessels. It'll autonomously and automatically do this with no control or no input from us. So this is a wonderful innovation. This has been around for several decades. And it's one of the reasons why we're able to do minimally invasive surgery. You know, my generation, and I think earlier generations take this for granted, but I still remember having to tie off mesenteric vessels. Every time you wanted to move a centimeter, you have to tie off a vessel. But this device, this example of energy, is a wonderful example of algorithms being utilized to give us better patient outcomes and better results. So what about this device, the Cyberknife? This has been around since 1994. And we're just going to skip it a little ahead. Now, the Cyberknife is an example of external beam radiation that uses a robot to give radiation therapy in only 3 treatments, as opposed to patients usually getting 5 treatments per week for 5 weeks. Because of this robot, you're actually able to give someone only 3 treatments for them to get fully treated for their tumor. So as you can see, the patient's lying on the table. They're about to get treated. He's got white strips on his chest, and the computer will actually sense as the patient breathes, it'll move, and it'll give radiation therapy more precisely, quicker, better than any human can do. And this is a beautiful thing that has been around for almost 30 years. This is an example of an autonomous intervention that, again, is better than a human. It's been around for almost 3 decades. It's used all around the world. And lo and behold, it's a lovely example of an autonomous action in surgery. And it's no coincidence why they call it the Cyberknife, because it, granted it's not traditional surgery, but it has replaced a lot of surgical maneuvers, and it was initially invented, I believe, by a neurosurgeon. So, it looks like my video got stopped. I'm going to try to go back up here. Yeah, let's go here. So you can also look at the collimator, which will actually precisely give the right amount of radiation. I'll give you a close-up of that in a moment. But this is a beautiful example of automation or autonomy in surgery. That's better than any human. Here you can see the collimator that works. It moves very quickly, and it'll give you a very precise treatment, and it's a beautiful device. So what about this device? So you don't use much of this in breast surgery, but this is from Medtronic. This has been around for over a decade. This is a powered stapler. It's now called the Cygnus Stapler. When I last used it, it was called the iDrive. It is a GIA stapler that has a sensor on it. When your tissue is too thin, it won't fire. When your tissue is too thick, it won't fire. It has 3 rows of staplers on each side, which are all, they get gradually smaller as you get to the center. And this will give you a better staple line, a safer staple line. It'll decrease your amount of leaks, of staple line leaks. And this is a beautiful example of a handheld robot that is doing an autonomous action. It's doing gastrointestinal anastomosis autonomously, some form of autonomy. Obviously, the entire anastomosis is not being done by the robot, but the actual staple line is. So this is a beautiful example. It's been around on the market for over a decade, and it's a beautiful example of autonomy. I would probably grade this as a level 2, possibly a level 3 on the 6 levels of autonomy. So again, this is made by Covidian. I don't have any financial relationship to any of these companies, though I certainly wish I did, because I think they're all wonderful companies. So that is another example of an autonomous action in surgery that has been around for over a decade. So next. What about the Da Vinci Robot? As we mentioned, the Da Vinci Robot is only level 1 when we look at examples of autonomy, because it's only an example of telemanipulation. Interestingly, however, there's another aspect of the new robot that people often overlook that is a wonderful example of autonomy in the operating room that is here today. Da Vinci has teamed up with a company in Germany called Trumpf, which is the table that the patient sits on. And it's the Da Vinci Xi is linked up with the table. As you move the table, the robotic arms, all 4 of them, will move in unison automatically. Before this innovation, whenever the robotic surgeon wanted to change the angle of the table, you would have to disengage the robot, move the table, put each of the 4 robotic arms back into the patient. And as a result of that, surgeons would kind of deal with angles that weren't ideal. Operations took longer. People would only use the robot for operations in the single quadrant. But now, because of the Trumpf, more complex robotic procedures are being done, such as the Whipple, such as gastric bypasses, because again, you have this automation in the operating room. It's saving time. It's giving surgeons exactly the angle that they want. I think it's going to be hard to quantify, but that's certainly going to result in better outcomes. So this is another beautiful example of autonomy in the operating room. So that's the integrated table motion. So this is a device that could possibly be used, I believe, in breast surgery. This is by a company called it's known as the Micromate robotic system. Its current applications include angio-CT, fluoro-CT, and fluoroscopy. It is the automatic alignment system that you're about to see is slated for release this past summer. I haven't seen the new device yet, but I think if I show you the video, it'll be more clear of what it is. So this is a device. It's a handheld robot. You put it onto a table, usually when you're doing percutaneous treatments, when you're doing biopsies or what have you. And the robot will use a reference point on the patient, and it'll automatically align your needle for when you want to do ablations. So all you have to do is, once the robot automatically aligns the system, is push in the needle into the patient to do the treatment, to do the biopsy, to do the ablation, to treat an endoleak or what have you. So this is a wonderful innovation. I think in breast ablations, this could be interesting because you could do ablations of tumors that you can't feel, you know, only of microclassifications or what have you. This is an example of someone getting an ablation, you know, posteriorly. So this is obviously this is not a patient who's getting a treatment for a breast lesion, but this just gives you an idea of what this device is capable of. And it's a wonderful device. We want to use it for our liver ablations. But again, I think for people with large breasts that have lesions that you can't feel, instead of having the radiologist maybe putting in a needle preoperatively and having the patient then come down into you, you could use this device in the operating room at the same time. Might be able to enable you to do more lesions, maybe have better results. Regardless, this is a beautiful example of automation in the operating room that mainly interventional radiologists can use, but also any surgeons who do ablations. So this is the last example I'm going to show you. This is actually already on your iPhone. You can download this application on your iPhone. So this program is called Jarvis. That's how you can find it on your iPhone Apple Store, or also on your Samsung phones. It stands for Just Another Rather Very Intelligent System, coined by Tony Stark from Marvel Comics for his artificial intelligence. Jarvis eventually became known as Vision, so it'll make sense why they called it that in a moment. This is what it looks like in the application store. Cholecystectomy Artificial Intelligence, the surgeon's Jarvis. Let's go to the video. So this is to recognize the triangle of Callot, the critical view of safety during a cholecystectomy. As you can see, while you're doing your laparoscopic cholecystectomy, your nurse, your assistant can just hold up your phone with your camera, can look at you while you're doing your cholecystectomy. As these criteria on the bottom turn from red to green, it tells you you've obtained that criteria, showing you that you can do a safe cholecystectomy. So this is a product that you can download right now. It has computer vision, and theoretically, it can help people around the world do better cholecystectomies more safely. And it's been around for over a year. So this is a more advanced Gartner hype cycle that I've developed. This came out in that Sensors article as I was telling you about. This shows you the amount of articles that are being written on artificial intelligence and robotic surgery. As you can see, we kind of hit a peak of inflated expectations around 2013. Then we dropped down to 2017. We had our trough of disillusionment. But as you can see, the year's not already up in 2021. And there's really starting to be another explosion of artificial intelligence in surgery. So I think it's a very exciting field right now. I think, as you can see, we have a lot of examples of autonomous actions. They're really improving at an exponential rate. Here, again, are some examples of autonomous surgery or autonomous actions in surgery that we talked about, such as the ligature, such as the Cyberknife, the powered Cygnus Stapler, the automated table with intuitive surgical and Trumpf, the micromat for ablations, and also the artificial intelligence with Jarvis. Here is an example of automated actions that we already have, such as vessel sealing, stapled anastomotic lines, automatic needle placement, motion scaling, and tremor reduction. That is with ophthalmologists, and also with the Da Vinci. Organ segmentation is also available. As far as prototypes, we have autonomous laparoscope tracking, autonomous aspiration. We have robots that can do aspiration autonomously. We have autonomous retraction, autonomous debridement, suturing, autonomous knot tying. Again, those are only in the prototype phase, so I didn't want to show them because I only wanted to show real life examples that you can use now. In the theoretical stage, the final few stages we need to get to fully autonomous surgery are things like situation awareness, phase recognition, autonomous pneumoperitoneal access, which is something I'm working on. We're actually using sound to help us with that. And finally, autonomous dissection. Da Vinci and the Versius robots, which are complete surgical systems, every time you do a procedure, they are downloading all of that data already to huge servers, and they're analyzing that data, and eventually, theoretically, they will be able to automate dissection. So that is already being worked on. There's actually websites right now where you have researchers asking you to download all of your information, your robotic information, into a server so they can start to analyze that, so they can start to develop robots that are going to be able to do autonomous dissection. So I want to thank you very much for your time. And if there's any time for any questions, I'm happy to have them. Please come to our journal, aisjournal.net, and thank you very much for this invitation.
That's great. Many thanks for the talk, and it's great. Do you mind stop sharing your screen, please?
Yes.
So we have now the panel discussion. There's lots of things to discuss. I find this very interesting concept. So we have Giuseppe Catanuto from Catania in Italy, and Giuseppe is one of the breast surgeons there. Also, we have with us Gerald Lip, and the best thing about Gerald is that he works with me. So Gerald is one of the radiologists that work with us in the unit here, and he leads on the AI projects in the breast imaging. And there's a big project here from Aberdeen and from Scotland looking at mammograms and screeners, and the AI is doing the second reads in many of those very interesting results. I've seen Nadine also, Haram, who's one of the, hi Nadine, how are you? She's one of the plastic surgeons from London, and Nadine also is also an entrepreneur, and she has her augmented reality also company. So there's lots of things to discuss here. Giuseppe, you're the clever man. Tell me, how are you going to start this discussion?
No, not really. Thank you. Thank you so much. I'm not really the intelligent man. I have a few questions, obviously, to all the speakers, maybe to Pedro, to Fabienne, and to everyone. My feeling is that we have fantastic tools in our hands, and we have robotic surgery. And about robotic surgery, I have my personal ideas that probably is not the right way that we are following with robotic surgery, but in the future it will be developed. But my concern is that we have these very good tools and prototypes because we mainly seen ideas, not really usable clinical practice. And my concern is that the regulatory framework in terms of medical agency, either in Europe or in the United States or everywhere in the world, is not going at the same speed. We can have the tools, but then the validation process, it will go from phase 1, phase 2, phase 3. It will take years because it is a very slow process that requires living patients. We haven't got the background to perform in silico trials and make simulation to develop at the same speed of the technology that we got in our hands. So I would like to see your point of view about this regulatory framework and technology. How can we match all together this?
Well, just in reference to that, I mean, it's a very important question, which is why one of my slides, when I talk about the 4 levels of risk, they have level 1 is a surgical instrument, which I find, very strange. But what that means is right now, if you develop any type of technology with the surgical instrument in the patient, as long as the technology is outside of the patient, you're able to advance very quickly. You're able to, it's a much easier regulatory process for the robot, actually, as long as the technology is physically out of the patient, which, we're among friends here, which is a little bit absurd, which is why I mentioned that they should probably think about another level of regulation. That said, right now, it's actually easier, I would think, to do innovation with a surgical robot as long as your technology remains on the outside, which is why we're developing a smart Varus needle right now, because all of our technology is on the outer part of the Varus needle. It doesn't go inside the patient, so it's an easier regulatory process. That said, in France, and maybe Fabienne knows more about this, the regulatory process in France has become much more difficult than say in Germany. And again, it's different than it is in America. So every country has different regulatory processes, which is making it a bordel, quite simply.
Yes. What is the opinion of the European surgeons about this? Pedro, Fabienne?
I would say that I agree with Giuseppe. It's a huge issue. It's a lot of money, time, and you spend years to get the approval. So probably what is discussing, Andrew, is more if you add something to, the Vinci robot or a CMR robot or a Medtronics robot is potentially quite easy. But if you start from ground, like Pedro, for instance, it's going to be a huge issue for him to get approval. Pedro?
Hi, yes. So, yes, it's absolutely true. So everything is going to be difficult. Now, the good news and the bad news. So first of all, these technologies, as Giuseppe are saying, are not currently in use because they are only in a research setting. So, and which will take years so that we be able to start clinical trials. So regarding the breast 4.0, we believe that in 3 years, we may start a clinical trial just to prove that it works. And only then we have to deal with artificial intelligence regulations, and the European Union is releasing a new regulatory law regarding how to use artificial intelligence. And of course, it raises a lot of uncertainty, mainly on investors, because if we want to build new medical devices, they have to be within a specific business model because they need to be lucrative. And so when an investor puts his money, he wants to receive money back. And so this means that we still have some time. So in the next 3 years, a lot of things were going on regulatory stuff. So we need to work on it with the legal departments, which is not going to be easy, but the technology is not ready yet. It means that we have time to deal with legal issues, and we have also need time to deal with the technology development that needed to be done in order to scale it and to reach a TRL 9 where we can apply it into the market. So once again, we have time, we need time, and in the meanwhile, some things will get clear. And obviously will not be easy. Even we have the digital surgery departments from Medtronic and Johnson & Johnson. They are already leading with some of these problems. They also already have some solutions regarding computer vision systems in the operating room of the futures. Instead of using infrared, they are using another type of cameras to avoid constraints when applying for certification. And so I would say, so I'm a breast surgeon and a researcher, and then as a researcher, so I feel that I have time later on to deal with it. But for the moment, on a low TRL, we just need to keep working on how to raise it.
That's great. And Nadine, you've raised your hand. So Nadine, if you want to comment on something.
Yeah, I probably want to take a step back. First, I'll just introduce myself. My name is Nadine Haram. I'm a reconstructive plastic surgeon at Guy's and St. Thomas's. I'm also the lead for innovation for the trust across all of King's Health Partners, which is a pretty big catchment area in the south of London. And separately, I'm a clinical entrepreneur myself. So I've set up a company that's looking at the digitization of surgery. How do we drive digital collaboration, immersive experiences, but more importantly, how do we think about the connected surgical care from capturing this information, removing that opacity, which we've had in operating rooms before, to think about how do we use this information knowledge to crowdsource expertise, raise standardization, reduce variation, look at accreditation and credentialing, which Pedro speaks about as well. And one of the things I did a couple of years ago, I was commissioned with a group of people by government to write the white paper for the future of surgery, which is on the Royal College of Surgeons website. And we started to define what were those thematic areas that the future of surgery would encompass. And we had started to map those out for 5, 10, and 15 years, of which things like computer vision, AR, VR, robotics, precision medicine and genomics, 3D printing, and a whole host of other components were outlined. And quite frankly, we thought these would take at least 5 to 10 years to materialize. But naturally, COVID has significantly accelerated the rate of adoption, and I think our willingness and our threshold to bring in and trial new digital solutions. Just to the point that you were making, Pedro, as well, around sort of investors, business, financial ROI, something that, someone's got to pay for it. I think ultimately the way I've always looked at it and the way we've been guiding a whole host of entrepreneurs in our ecosystem and in our medtech hubs, and even how I've come to creating Proximie is if it's solving a problem and you're either improving quality or outcomes and reducing cost, then you fit into this sort of value-based healthcare approach. And ultimately, there will be ways to deliver a return on investment from a financial perspective. And so I would almost encourage people to not worry as much about financial return, which I know is not your intention, Pedro, but very much what you're describing is this really solving a problem? Is there evidence that it can make a difference either to patients or to the healthcare workers or to the health system? And as such, what is the most appropriate business model, but also adoption and deployment model to do that? Because it's almost easy. I don't want to say it's easy. I don't want to insult any engineers here, but creating computer vision algorithms and AI algorithms is not the difficult part. Those are largely commoditized in the market today. If you look outside, pretty much PhD students in their first year are creating these algorithms, if not earlier. The challenge is, how do you now deliver a change management process, or a deployment or implementation process where now clinical care or care pathways are redesigned to adopt these? And so there was a question, I think, in the Q&A as well about, looking at how do you globalize artificial intelligence and advanced technologies in underdeveloped countries as well? I think ultimately, once you think about the problem you're solving and the value you bring, the design of how you deliver the product and how you make it accessible and available is almost the most important thing. Because the more accessible, more available, and more solving it does, then all the other problems of like regulation and others will have to fit into place, because there's too much of a pull or momentum to say we have to change because these solutions are actually making a difference. So it was just a bit of a side kind of step into this discussion, but some very interesting points that everyone makes.
That's great, and thank you for answering that question. That question was from Professor Mustafa Ait Isa, and Mustafa is the president of the Plastic Surgery Society in Algeria. I know him personally. He's a great chap, and many thanks for joining, Mustafa, and I hope that Nadine answered the question that you wanted. Fabienne, you have your hand up. You want to mention something, Fabienne?
I think Nadine said almost everything, but I would like to I wanted to say that it's totally depending on the technology, because if you are talking about robotic or about viewer, it's not the same. For instance, for Avatar Medical, it's a viewer, it's a platform. So we'll get the FDA approval and the CE marking next year to make it available in clinical routine. And the most challenging task is to really find the place where you can use this new device in the routine of every surgeon, radiologist, and patient. That's the most complex task, much more than getting the FDA approval for a viewer.
That's great. And Gerald, as a radiologist, you lead on many things in AI, in imaging. For example, the avatar, which Fabienne talks about, and you've seen it in Chicago last week. Many times in the MDT, there's a multifocal disease, and I just go on the screen to have a look at where is the tumor now one, where's tumor two, is this conservable or not? But with such a machine, that will make my life and your life easier, isn't it?
I think so, and it also makes the patient's life easier, because this is a machine that can be used and very easily visualized to share with the patients and yourself in planning the surgery. As Nadine has said earlier, if there is a use that you can find that works for the patients and works for the clinicians, then there will be a market for it. There will be a reason for it as well. Using Avatar, which I did trial at RSNA in Chicago last week, it was very interesting because I could see the extent of the tumor. You could see the spicules as it was reaching out across and seeing other lesions. And I could see that in a way you could really bring that message across, whether it's in medical education to students or in surgical planning as well. And other fields then will lead into that field as well, Yazan.
That's great. I know that Jill, she's been very kind, and she joined us. She's in the airport in Houston going back home, and I cannot thank her enough for that. But let's go back to the globalization question by Mustafa, because the globalization is not only about that, it's also about training, and also something that Andreas Karakatsanis, who's one of the surgeons from Uppsala, is mentioning. Do those technologies, will they help in training, but also will they facilitate more surgeons performing some procedures without lots of training? Any thoughts about that, Jill?
So first of all, thanks for having me. And I feel like I just need to say I feel like coming together internationally and a webinar like this is one of the good things that happened with the pandemic. So I think this is a great webinar, and thanks. I think the way that we have trained traditionally, where the medical student watches and then the resident assists and then the chief resident does the operation with the primary surgeon there, and it's almost like like you're an assistant that has to come all the way through. And now training is very different for the residents in the United States. We do so much with simulation because there's a lot of regulation on surgeons. When I trained, the staff surgeons wouldn't even be in the room, and they were running multiple rooms. And now there's so many regulations that you can run room, and the attending surgeon has to be there the whole time. And every time there's new technology that the attending surgeon has to learn, they have to learn it first. So the residents really, I think, don't and there's an 80-hour rule regulation, so they're in the operating room less. So they're really, the trainees of today have a much less of an opportunity to have experience. So I think it is actually critical that they have simulation. And I do think that this kind of AI training is going to only become more important as time goes on.
That's great. And I always, when I saw those, the VR tech, I always thought that this is a great training opportunity, not only for surgeons, also for medical students. You can teach anatomy beautifully using that VR machine. You can teach the residents and students things, and you can teach colleagues how to do things or take them through things. But you need to have that balance of when are you teaching and you're supervising enough and we're not doing things enough. Giuseppe, you have your hand up?
Yes, Yazan, I would like to go back to Pedro's experience, and I'm wondering, now I understand that he's using sort of a mechanistic model for transformation of standing position to supine position. And I'm wondering if this system is designed to learn and to create, let's go back to the topic of digitalization, digital twins, and chimerization. If you are able to create virtual dummies in a way using this system, so that you can, create digital twins that you can move, that you can use for other experience in this field.
Hi, Giuseppe. Thank you for your question.
Hi,
so,
Pedro.
yes, of course. So if you think on autopilot cars or autopilot systems on cars, so each time a car is running on an autopilot is helping to improve the system in order to improve the autopilot system. Now, we started a small study with 15 patients. Now we have more than 70, and we will continue to upgrade our number of patients. Now, what happens and what you will do is that you will improve your methodology with artificial intelligence, namely deep learning, and you will have somehow, as we are talking about simulations, so it means from the representation A, you get a simulation B model. Now, the B model, it represents here the post-transformation from prone to supine as any other model. Well, it could be, this is the problem of breast cancer, but there are other problems that we might target. Now, what we can use, it's just like, for example, when you have someone that is faking a dollar bill, and then you have a policeman that will check if that dollar bill is fake or not. So this is the way how we are going to improve our models. So we will generate simulations, and then we will have a discriminator, which will be the good judge that will say that if your simulation is good or not. For that, you need ground truth. So you need a way of acquiring a specific patient in the position that you want, so that you can simulate your post-transformation and then to correlate with the ground truth that you get. So whenever if you have 400 patients, you will get high fidelity models. But then if you get 1,000 or 2,000, if you keep continuing acquiring the patients, then it's a mathematical equation where you will actually get high fidelity and reliable and accurate 3D models. So this is true for breast cancer, but it's true for anything. So what you need is good data, a good methodology, a ground truth to distinguish between a good simulation from a bad simulation, and then at the end you may be able to improve any model that you have. So at the end, it's just applying advanced statistic methods to imaging data. So we do know how to do it on structured data on Excel files. Now we have to improve how to treat, how to model, and to statistically apply advanced methods for imaging data like MRI or any other one. So we are experiencing now a way of having in our packs not only MRIs and mammograms, but also digital surface scan of our patients that we can help us on how to build these models.
And there's a question from Stefan Wojciechowski, who is one of the senior surgeons in Europe, asking about Avatar. Stefan, go on the chat section. I think Mary from Avatar is putting the contact details there. And there's a link in the email that I sent yesterday from the iBreast Book newsletter. So you should have received that. And Nadine, you have your hands up. You have something to say?
I just wanted to add to what Professor Jill was talking about with regards to the new models of surgical training and how we really need to start thinking about addressing the gaps and the patients that, the huge gap between the number of patients that need care and the number of clinical experts that are available to do so. There's many esteemed speakers on this panel. I spent about 10 years involved initially in global health. We're traveling to many parts of the world looking at capacity building and sustainability in surgical care. I also spent about 5 years working with device companies trying to understand that sort of acceleration to product launch and training and upskilling in Prof Ed. And the reality is, in that experience, what was clear is that something which is very familiar to all of us, the see one, do one, teach one model is quite archaic in the way that we deliver training. It's very siloed. Nothing is sort of connected. There's no way to really build on that model. It's worked, it's worked fine to date, but I think we all agree we can do better. And we need to also think about how are we going to train the surgeons of the future. There's been a lot of disruption to theaters and ORs over the last few years, where we need to think about how do we accelerate learning opportunities, how do we make these moments available, and how do we run services where we don't have to be in the OR with the trainee the whole time. And so that's something that we've worked on quite a lot at our hospital, at Guy's Hospital, with solutions like Proximie, and not here really talk about the company per se, but talk about these typical applications where you can actually, sitting at your laptop or phone, virtually scrub into an operating room, collaborate using augmented reality and immersive tools, engage in that case, bring that knowledge, and then perform it and perfect it. And so we changed this idea of see one, do one, teach one to the 3 Ps: prepare, perform, perfect, all on a single digital continuum. You can dial into cases every day. And if you're a medical student or a senior surgeon looking at a new device, we've seen many of our own professors in our hospital, like Ash Katari, trialing new devices and techniques, having also reps dialing into Proctor remotely, but equally having other breast surgeons dialing in to watch how he's using these new devices. The best part of that is then that case is recorded, and then you can go back and review that for performance advice, performance metrics, and others. I think there's enough overwhelming evidence in the literature around video performance metrics, acceleration of opportunities. And so it's exciting to hear so many speakers on the panel today talking about more creative ways of addressing those challenges. And hopefully we will start to continue to see these becoming more mainstream over the next few years.
I think it's not only for surgery, also for imaging, for many other specialties. You can see a biopsy gun not shooting if the augmented reality is saying it's not going to hit the target, or is going to cause a pneumothorax, or going to cause something else. So I think, as I said, it's not the sky is the limit, is the headset is the limit in the future. I think we can do many things, but time will tell.
We've seen it used in imaging. We've seen it used in colonoscopy and wound care. And the great thing is, because you're recording all these cases, you're capturing a heterogeneous data set from multiple hospitals. And so we've now then been able to build AI into it to support decision-making and bring it back full circle. But it's the deployment engine. If you just walk into a hospital and say, I have an AI algorithm, do you want to use it? It's a bit harder to sort of deliver that solution. But if you say, look, I have an end-to-end platform that's going to help you. It's going to help you collaborate. It's going to help you record your cases, to move to video logbooks. It's going to capture and understand your performance better. It's going to support scrub nurses to get trained. It's going to support physiotherapists to know what's happened in the case, and many other kind of value points. I think you'll see more of an acceleration of adoption in that sense, as opposed to a host of lots of point solutions that just do kind of one piece of the big puzzle.
So, Gerald, do you want to say anything about radiology? Have you had up?
Oh, I have something a bit more interesting to ask in the other way, which Andrew probably referenced earlier when he was talking about cryoablation, which is done by the interventional radiologists. Do you think there's a role where radiology and interventional might take over some of the breast surgery if we have AI directing us in those areas? We're already doing some of that with excisions. So we have the lenses and we know where to do the biopsies. We can also do the excisions. Do you think that that's a bit controversial to a group of surgeons? But what do you think of that?
Let's hope we don't become the vascular surgeons of the future, where interventional radiology has taken over most of the operating. What do you think, Andrew?
Well, you know, where I used to work in Paris back in 2006, 2007, with a guy called Brice Gaillet, and he had a department of the surgeons and the gastroenterologists together. It was a department of digestive surgery. I actually feel like interventional radiology, gastroenterology or endoscopy and surgery are fusing into the same field. So I actually welcome it. I think we should all join into the same field, which is why with artificial intelligence surgery, I keep referencing interventional radiologists or gastroenterologists. It's all a form of minimally invasion, which is the future. So I encourage it and I embrace it, you know, but I think the main problem is that surgeons resist it so much. They don't embrace the new technology. They don't embrace the techniques or the innovations, and they should. Otherwise, we will end up, like the cardiac surgeons of the past. You know, if you have to embrace the new technology, you have to be abreast of it. That's why we created the Artificial Intelligence Surgery Journal. We do not want surgeons to be left in the dust. We do not want other people dictating to us the future. We want to dictate it to us. And one of the main questions, which I didn't have a time to really talk about, is the complete surgical system, the complete robotic system, the best way to go, or should we keep surgeons in the loop with handheld robotics? So I actually just published an article on my website about this, showing that handheld robotics might have some advantages to the complete robotic surgical system in treating colorectal liver metastases. So very excellent question, and a very, very important topic that's important to me.
I think, Andrew, we can change the question to Gerald and tell him if the AI is going to read the mammograms and we learn how to do ultrasound scans, do we need radiologists in the future? Pedro, you have your hand up.
Yeah. Okay. So I just want to add something to the Nadine what just said. So, of course, we spoke about the difficulty of using currently so these devices are not commercially available. So we need to develop them. But the augmented reality platforms are there for many other use cases. And one of those that will be applied immediately will be on education. So augmented reality and virtual reality, which will set up a new methodology to teach surgeons. Now that needs also to be proved within clinical trials in order to see if a surgeon trained with a virtual, then on an augmented reality, and then on real things, it raises his performance. So we need to follow we need to follow that path in order to prove that this methodology is okay. I believe it will. So in order to work on these things, we have to believe it first and then to prove it then. And so we need the right methodologies to apply for virtual or augmented reality. And one thing that will be very interesting is the use of sensors on surgeons. So you do know that when you are nervous and starting a surgery, your heartbeat will accelerate. You can be sweating. Now, HP has launched a very funny virtual headset that allows to check how nervous you are, pupil dilation, heartbeat. And so it could be also had some measuring and some data on how a surgeon behaves when he's practicing a specific procedure. So we need to know we need the right methodology to know how to integrate these data in the pipeline in order to, on a proper way, prove that using these new methodologies on surgical education can be valuable by measuring specific outcomes, by measuring each surgeon's performance. Now, that's one way to go. That's something that we can start doing now because we don't need specific regulatory, we will not have specific regulatory issues applying it. So once again, we need to go back to school, to universities and medical schools to start applying these methodologies, evaluating these methodologies, then to say, with this tool, you can get better surgeons. So that's very important.
That's great. And can I share my screen just for a minute? Because I just want to mention a couple of things. First of all, everybody will get a certificate that has attended with CPD points, 1.5 CPD points issued by the Royal College of Surgeons of Edinburgh. Just give me a few days. Please don't start emailing me today or tomorrow about where's my certificate. Give me about a week's time, because we'll end up issuing more than 500. We are planning more webinars for next year. The number 24 is going to be on the first week in January, on the 8th of January. And we chose the best, not the best talks. All talks are great, but some of the best talks from the past year or 1.5 years. We chose the St. Gallen's conference update from Michael Gannon from Vienna, and Austria has a great talk a few months ago. The septal-based mammoplasty by Mustafa Hamdi, that was, I think, in November time, and Mustafa had a great talk in that webinar and had lots of emails asking about that. A pre-pectoral implant-based reconstruction, do we need a mesh? And that was a talk by Cicero Urban more than a year ago, but I had loads of emails asking about talk after the webinar, so we're going to play that again. And pre-pectoral hybrid and the synergy of filling of breast implants. Brilliant talk also by Philip Stillart. They'll be all replayed on that day with the excellent panel. Ash was supposed to join us today, but I think Ash is now on a plane somewhere coming back from San Antonio, so he couldn't join us today. This is my family, so I'll just close this and I'll stop sharing. So any final comments, everybody? We still have about 350 people online. Any final comments? I think that's it then. It has been great. Many thanks for all the speakers and for the panelists for giving your time over the weekend to be part of this. Many thanks for Avatar Medical for sponsoring this, because with all sponsors, we can continue those webinars to run for free for everybody. And for people in the States and South America, have a lovely day. For people in Europe, have a lovely evening. For people in the subcontinent, have a good night. And thank you.
Thank you.
Thank you, Yazan.
Congratulations.
Bye-bye all. Thank you.